Welcome to BioBalance Healthcast. I'm Dr. Kathy Maupin.
And I'm Brett Newcomb. And today we are continuing our conversation about an article that was in CNN Health on December the 28th of 2011. And this article was a discussion of and criticism of anti-aging medicine and its practices. And we are responding to segments of that article. And if you saw our last podcast, you'll know. And if not, and you'd like to go back and check it, you can do that. But I want to start today with quoting something and then asking from the article and asking Kathy to respond to it. The quotation is from a doctor named Thomas Perls, MD, an associate professor of medicine and geriatrics at Boston University School of Medicine. He said, "It's also hazardous because most age-erasing doctors aren't trained in using these powerful substances. It's outrageous that people think they can prescribe these toxic hormone soups." So he's talking about in the discussion of the article, just before your head blows off, he's talking about anti-aging doctors who prescribe hormone-based substances and drugs that they generate themselves and go to compounding pharmacies and put together and put out. So we need to talk about the hormone soup and the toxicity, and we need to talk about compounding pharmacies and how they work.
Right. So I think the first thing to address is that anti-aging doctors are trained.
Take a deep breath.
I know. We are trained, and we couldn't do this if we were not trained. However, there are some people out there that are not trained and try this. I have to say that's in every specialty. That's in, they do things that are outside and they're not trained. That is dependent on the doctor itself. It's usually less than 5%. You just have to be sure that your doctor knows what they're doing and that that's what they do is anti-aging and not just do it on a little here, a little there when they're doing something else. That's all we concentrate on is replacement of hormones.
And is it worth making the distinction? Because they use the terminology anti-aging. It isn't an effort to stop you from aging. I mean, that's ridiculous. You're not going to stop aging, but it is an effort and a concentrated effort to improve the quality of life as you age.
True. That's right. And what happens is we age as we get older. We lose one hormone after another. First testosterone.
The system just starts to run down.
And it starts running down. And we weren't meant to live past 50. So because medicine has given us the opportunity to live to a very old age by giving us lots of medicine for blood pressure and heart disease and things like that, we need to have something that helps us live to an old age well and healthy. Okay? So for my response to this is we're not trying to stop aging. We know people age, but there are many diseases secondary to the loss of hormones and many symptoms that are miserable and break us down while we age. Why should we not be healthy as we age? Why should we be in a nursing home when we're 70 or 80? Why should we ever have to go to a nursing home? If we keep our hormones together and we replace them, and we're healthy in our lifestyle, eating right and exercising and all those things, which you feel like doing when you have your hormones, then we can avoid those ultimate outcomes that is going to bankrupt America right now is nursing home care. So he's dealing with old people who are already in that circumstance. That's what geriatrics is. I don't propose we give them hormones. I propose that we start with younger people and replace them when they start becoming missing, because that's what anti-aging doctors do. And then we avoid all of those diseases that the current geriatric population
has. So it's a type of preventative
has.
medicine
Yes,
that
it is.
delays the inevitability of some of that deterioration.
Well, we're going to die.
Yeah.
We'll all die. And I don't think it changes.
Nobody gets out of here alive.
Yeah. We're all going to die, and we're all going to die at a certain age. I don't think that this necessarily prevents us from dying of something.
Right.
It just makes us healthy till we get to that point instead of sick for 30 years. Why should we live a life that's sick for 30 years? So that soup, he's the soup Nazi on Seinfeld. No soup for you. You must age. You must get old and debilitated. I mean, we're offering soup and our door's open. And anti-aging doctors are very well qualified to do this, and we do it with laboratory, and we follow up lab, and we make sure that there aren't side effects. We're very careful about all of that because we know we're under scrutiny.
Well, and you should be under scrutiny. All medicine should be under scrutiny. The question is, what is the data? What is the evidence? What is the progression of change. And so when you make a categorical denunciation or broad sweeping criticism, those are handy dialectical arguments, but it's not good science.
That's true. And he states that there's no proof that you are less likely to get diseases. That's wrong. There is proof. In the endocrine journals and in the neurology journals, it states that if you replace testosterone, you gain 10 years, you delay the onset of Alzheimer's or dementia 10 years. And if in women, if you add estrogen to that mix, you delay it another 10 years. So if you were going to get Alzheimer's when you were 65, you'll now get it at 85. That's a huge benefit. You can be productive for 20 more years of your life and not weigh on your children with illness.
Well, and one of the points that you make in the book that you're writing is that the process of that is something that you want to take a look at, because you want people to get treatments that improve the quality of life and to have them make good medical decisions. And so what you are advocating, and what I understand that other anti-aging doctors are advocating, is a more global look at the syndrome or the diagnostic issue and not symptom management. If you just manage the symptom of, it's a real problem, but it's a symptom of a larger issue of osteoporosis or weight gain or hair loss or libido loss, and you medicate each of those individual symptoms, then you have people that are spending a lot of time and money and a lot of resources on medicines that might be avoided if you looked at the syndrome.
My patients don't need medicine for osteoporosis because estrogen and testosterone, along with calcium and vitamin D, which is our supplements, is a better bone builder than any of the bisphosphonates, the Fosamaxes and everything. And I don't want Fosamax to come out after me, but you just don't need those if you're replacing estrogen and testosterone. Seriously, that's not necessary. Osteoporosis is one of the big things we try to fight. We fix that. We prevent that. We reverse that by giving these hormones. Usually within 2 years, if you have osteopenia, you're back to normal if you take estradiol and testosterone in your late 40s or 50s. Sometimes even into your 60s, it can reverse it.
So in the article, they talk about fad diagnoses, and they talk about treatments for that. And one of the things that they talk about is heavy metal toxicity and chelation treatments for that. And when I was discussing with you in advance of this podcast, you had a response about that as well. Would you like to?
Yeah. I actually, in my office, I do some hair, not very much, but some hair analysis for people who I get 90% better, but I can't get them that last 10%, and there's no visible reason that they shouldn't feel really good. So I look for heavy metal toxicity, and it's stored in your bones and in your hair and in your nails. So of course, the best way to check that is not to drill a hole in your bone, but to cut some of your hair off, and then evaluate it for heavy metals. When we find that, we use nutrients. We do not use chelation therapy. I look at every benefit and risk, and the risk of chelation therapy is very high. You can have some big renal problems and liver problems. I do not use that, don't advocate it. But some people do get it and are fine in the right hands. I'm just not somebody who uses that method. I use a very safe method of using supplements to get rid of the heavy metals, to get them out of your system, to chelate them, but not like they're talking about an IV and stressing stressing kidneys. We're just doing it on an everyday basis for 6 to 12 months, and then we get rid of most of them. So the way they look at it, they blanket look at they make a global testing. Indictment. Because they know that there's heavy metal poisoning and it's toxic to people. And if we've had it, especially those of us who grew up in the 50s and 60s before we were protected from it by law, we have it we had in our foods and our paint, we had lead, we had mercury and aluminum and tin, and we have to know what's bothering us. And we should be treated. They do tests like this for heavy metal toxicity, but only when you're like on death's door, when it's almost impossible to get you back. And chelation is actually a medical treatment that is done by MDs, so it's not something that people just go do for no apparent reason. At least I don't think so. I want to go back to pharmacies.
Yes,
compounding
yes,
pharmacies,
I do too. Yeah.
Because that's very important. They say we write a prescription for a soup from a compounding pharmacy. Let's go back in history. All pharmacies were compounding pharmacies before the 40s. before we had all these drugs that were made by pharmaceutical companies. Every pharmacy made up your prescription for you. And these pharmacists that are in compounding pharmacies now are people who have kept that talent and that process, and they still know how to do that. Now, they can do it with vitamins, they can do it with B12, they can do it with hormones. So many of them they can even make Viagra for you, but not Viagra. A little different.
Not the brand name.
Not the brand name.
Right.
But they can compound these things, and they work better than when we use something that a pharma uses, partially because they're using substances that are made into hormones from plants. And that is much more accepted by the body than is anything that's made in a laboratory.
Right.
So when by being the doctor, I choose my pharmacy. I choose a pharmacy I know is responsible, that when they say it's this dose, I ask for a dose, the dose is the right dose. Every time the patient gets the same thing. They're very regimented.
And you supervise that.
Right. I wouldn't choose a pharmacy. I only give a few pharmacies as referrals for my patients to get their prescriptions. However, I use pellets from a pharmacy that I trust, and I know those pellets, estradiol and testosterone, are made the same every time. They've been in business a long time. They are very reputable, and I know they're pharmacists. I talk to them. So you have to have a doctor who does follow up on that, who knows enough and has enough of the practice being hormone replacement that they know they're pharmacists. I don't recommend just sending you to a pharmacist to tell you what you need. I think that you should go to a physician who writes a prescription. Sometimes it's a little backwards because doctors don't really know how to compound things, but people want them. Instead of sending them to an expert in the medical world, they send them to a compounding pharmacist to do that. So I'm not really an advocate of that. I've seen some problems with that. But everybody's got their own opinion on what their patients need based on science and also based on how their patients have responded. And my patients have responded beautifully. The other thing people need to know is the FDA. The FDA does monitor compounding pharmacies.
Yes.
They go in, they check them out, they make sure their doses are their doses, they check and make sure their process is sterile. They go in and check them all. If they are not checked out, they can't send out prescriptions.
Well, let's tell the audience why you're making that statement. The article quotes Dr. Stephen Goldstein, who is, professor of obstetrics and gynecology at New York University School of Medicine. And he says, it is this customization that is most troubling to mainstream doctors. It involves taking a prescription to a compounding pharmacy where pharmacists mix ingredients as outlined by your physician, and the resulting concoctions are not approved by the FDA. When the FDA looked at compounded medicines, 43% of them did not have the things that they were supposed to have, Goldstein says. And he doesn't say when or where he got this information. That means that the drug you're getting may not work or may have unpredictable side effects. And the reason that I'm pointing this out is the argument that Goldstein makes, he doesn't cite a reference, but he does cite a reference in another part of the article about the Women's Health Initiative, which I would like to come back to as well. Another hot hormone, this is a quotation from the article, is bioidentical estrogen. For decades, women have relied on synthetic estrogen to relieve women's menopausal symptoms such as hot flashes and vaginal dryness. But when the Women's Health Initiative study on estrogen and progestin therapy was halted in 2002 due to a possible hormone-related increase in the risk of heart disease, stroke, blood clots, and breast cancer, some doctors touted bioidentical versions made from soy and yams as safer, although there's no proof of that. And then he goes on. So talk to me for a minute about the Women's Health Initiative.
Well, the problem here is he's using the Women's Health Initiative then did say that, but has been discredited because the study actually found what was on the front of the newspaper, hormones are bad, dangerous, really was not estrogen. It was the progestin, which is a synthetic progestin, Provera, and it was in the mix of estrogen, Premarin, and Provera. That was the arm of the study, or the group of women who had higher risk of heart disease and higher risk of breast cancer.
The ones taking progestin.
Right, but the ones who didn't take progestin, who just took Premarin, and I don't write Premarin, it's an oral estrogen. I think that it has more side effects than what I do, but it showed less heart disease, no change in breast cancer result over people who took nothing.
Right.
So even an oral estrogen, which he's misquoting the results, and you have to read the study and read the retraction of the study to understand how this goes, but he's using a bad argument, a bad study, not giving you the updated information, and then he's then criticizing bioidenticals, where bioidentical progesterone is safer than progestin. It does not cause heart disease. It does not cause any of the things, breast cancer or anything else, like progestins do. There's a chemical reason for that, and that's because progestins are metabolized into estrone, which is old lady estrogen, and estrone can cause those things. But progesterone, natural progesterone sublingually does not. And so we are better, and there are studies on that. You don't see people who are pregnant getting progestins. They get pure progesterone. That's
So the conclusion then is that we're not necessarily impugning this physician. We don't know him or his full medical spectrum of work, but what we know is that he's citing a reference that's out of date in support of an argument that's inaccurate. And so when you look at those kinds of statements, if you have that information, you can make better medical decisions for yourself. And this article, if you go and read it on CNN Health, you'll find it's a full spectrum survey of a lot of different anti-aging issues and medicines and hormonal treatments. And the reason that we're having this conversation is to talk more specifically, not in a broad-based examination, but more specifically about the work that Kathy does and the kind of hormone treatments and replacement therapies that she utilizes and why, and emphasizing what her research and credential experiences are.
Thanks.
So,
I think it's very important to know that who the doctor you pick is very important, and it's very important that they're managing your care in terms of looking at laboratory, not just saying, here, take this.
or quoting something they learned 20 years ago and haven't updated their knowledge base on.
Right. Every month there's new information about men's and women's
And
hormones.
it's so hard to keep track and to know the good science. And it takes a really dedicated physician to do that. One last issue that I'd like to discuss today is more of a legal terminology than a medical terminology, but it's a reference that's used consistently across both spectrums, and that is the term standard of care.
Right.
Can you speak to, because people say, well, that's not the standard of care, or in my business, for instance, counseling, if there's a malpractice suit, what you have to prove isn't that you didn't do something wrong, it's that you did what was the standard of care in your community by professionals with your credentials.
Right.
So let's talk about standard of care.
Okay, well, this is a very interesting, it's a legal and medical term. It's an interesting term. Standard of care is translated into the least amount of medical treatment that is acceptable by a physician. Okay? The least.
Okay.
Not the best treatment, not the optimal treatment, the least. And medicine today, I hope not forever, is based on providing the least amount of medical treatment that they can to get you rid of a symptom or a disease. So standard of care by both lawyers and doctors is run by that. When we get guidelines from the American College of OBGYN or endocrinology, we get guidelines that give us the standard least amount of care that we can give and not get sued.
It becomes a real challenge when you're in the field of preventative medicine.
Yeah.
You know, the old Murphy's Law thing, if it ain't broke, don't fix it.
Right.
You know,
but someday it'll be broke.
But someday it'll be broken, then you can fix it.
But if I can see, it takes a kind of a vision. I can see what's coming. I can see what's coming for me if I don't replace my testosterone.
Right.
I'll be having Alzheimer's in about 3 years because I can't think without it. But I mean, there are a lot of things that I can see in the future because I know the medicine, I know the science. I'm very careful with how I manage patients. I follow laboratory. Part of what they say, there's a nugget of truth in what they say. Because some doctors who give hormones just give them and say, see you later, bye-bye. There's an example that's most poignant in the men's treatment. When we give men testosterone itself is not what causes prostate cancer. We've talked about that before. When we give men testosterone, we are not putting them at risk for prostate cancer when it's pure testosterone. It's only when we give them testosterone, and if they genetically make a lot of DHT, then they can stimulate growth of their prostate and growth of prostate tumors. So here's the deal. If you manage this properly and you give somebody testosterone, and then you watch whether they convert to a lot of DHT and estrogen, and if they do, you treat that. You troubleshoot it.
Adjust the delivery of the medicine.
You give a different medicine
Right.
or a supplement to stop that conversion. Then you've given that medicine safely. That's what we should all aspire to. And we should all aspire to not the least amount of medicine we can give somebody. I don't mean medicines. I mean, we need to aspire to the highest level of medical treatment for a patient, not the minimalist level that medicine is going for. And it's been my objection to medicine all along that they won't pay for or allow us to prevent illness in people, because that's how we're going to get out of the
That's your
situation
objection to insurance companies, not
and,
medicine.
Well,
And
they follow the insurance companies.
Right.
They have a lobby. They
the
both
tail
lobby
wags the
together.
dog.
Yeah.
So we could go on forever. This is a very passionate topic for us, and we may revisit this conversation. If you have a contribution to make to this conversation, you can reach us directly at
biobalancehealth.com, or you can call my office at 314-993-0963, or you can email us at podcast@biobalancehealth.com.
and you can always reach me at my blog, which is brettnewcomb.com.